Rare co-infection in immunocompetent host with Leclercia Adecarboxylata bacteremia complicating a case of MRSA pneumonia. So Leclercia Adecarboxylata is a gram-negative bacilli, which hasn't really been documented as a human pathogen. And the cases that it has been documented in are more commonly associated with immunocompromised hosts. Um, it's typically it's typically causing urinary tract infections, catheter associated infections, soft tissue or cutaneous infections, and less commonly associated with endocarditis and bacteremia. It's also less commonly associated with infections in an immunocompetent host. Here we have the case of a young female without any risk factors really for immunosuppression who developed septic shock secondary to MRSA pneumonia, complicated by concurrent Leclercia Adecarboxylata bacteremia. So she's a 28-year-old female, past medical history of psychogenic non-epileptic seizures, obstructive sleep apnea, and schizophrenia, who was found down by a bystander at the side of the road. They called EMS, and when EMS came to her, they reported she was having some witness seizure activity, which terminated with 5 milligrams of IV midazolam and nasal Narcan. When she presented to the emergency department, she then progressed to status epilepticus, for which she was intubated for airway protection. She was also sedated and taken to the ICU. Her labs, imaging, and clinical presentation were suggestive of multi-organ failure secondary to septic shock. So she was started on fluid resuscitation, empiric antibiotic coverage, vasopressor support, and she also required CVVHD as well. Throughout her hospital course, she progressed to severe acute respiratory distress syndrome, ultimately requiring prone position and nitric oxide. Her PF ratio was 118 on a PEEP of 12, FiO2 of 70. She had an infectious workup which revealed respiratory cultures which were positive for MRSA. Her blood cultures grew Leclercia Adecarboxylata and MRSA. Despite maximum pressor support, supportive care, she received bicarb. She ended up developing some arrhythmias. Initially, it was atrial tachycardia, and then she began developing bradyarrhythmias and idioventricular rhythm. She ultimately expired shortly after the bradyarrhythmias. So Leclercia Adecarboxylata is historically viewed as an environmental pathogen found in water, soil, and food, and primarily regarded as an opportunistic infection. Advancements in microbiology has led to the development of different gene sequencing, which results in increasing the recognition of this bacteria as a clinically relevant human pathogen. In immunocompetent hosts, infection with this pathogen tend to be more polymicrobial, which was the case with our patient here. And when presented in this polymicrobial fashion, the pathogen has the potential to cause multi-drug resistance. In the literature, I saw that there were also ESBL producing strains which have been emerging, for which MRSA has been required in those cases. With our case, the patient really does lack any of the typical risk factors that I saw in the literature. She didn't have any catheters, she didn't have any recent trauma, no immunocompromised state. So, really, there wasn't anything that could suggest why she was susceptible to bacteremia with this pathogen. This case highlights the importance that Leclercia Adecarboxylata can infect hosts beyond the known immunocompromised group, which has been documented that it infects the immunocompromised group, but not so much in the immunocompetent group. So further research is needed to investigate the mechanism for infection of an immunocompetent host. Thank you.